Hi, I'm Dr. Bill Gradishar, Professor of Medicine at Northwestern University, and I want to welcome you to this Yerba YouTube video that's going to focus on the issues of pregnancy and breast cancer. And this is a broad topic. Obviously, getting pregnant is one of the goals of many young women, and if you have a concurrent diagnosis of breast cancer, that's one issue. The other issue is if you've had breast cancer and then still want to get pregnant, might it have some impact on the overall outcome of your breast cancer diagnosis? So let's sort of break those things down, and then we'll also talk about breastfeeding after a diagnosis of breast cancer and what the potential implications are of that as well. We do rarely see patients who present with pregnancy and a new diagnosis of breast cancer. And this can be quite challenging, of course, because one of the goals of therapy is to reduce the risk of the disease ever returning and at the same time not affect the pregnancy in any sort of adverse way. And over many, many years, we've gained an experience knowing what things are safe to do during pregnancy, which things should be avoided. So in a patient with a new diagnosis of breast cancer during pregnancy, obviously we confirm the diagnosis with a biopsy. The extent of imaging can sometimes be limited because certain x-rays may, or imaging studies may expose the developing fetus to unwanted radiation therapy. So we really limit the amount of imaging that is done. As to what things can be done for the diagnosis of breast cancer, you can do surgery. Obviously, you want to make sure that high-risk OB/GYN is involved when surgery is being considered, but that can be done. Radiation therapy is often deferred until the delivery of the child. We don't want to expose, again, a developing fetus to radiation therapy. We not uncommonly will consider chemotherapy, but only certain kinds of chemotherapy, and always after the first trimester. So after the first trimester, recipes of drugs such as AC and anthracycline and cyclophosphamide have been used for many, many years and found to be safe. We define that by knowing what the outcome of the pregnancies were following patients and their children after they were treated during pregnancy. And there appear to be no increase in adverse effects to the children compared to a normal population. So as long as those rules are followed, you can administer certain kinds of chemotherapy safely. Things we try to avoid: anti-hormone therapy until delivery. We also try to avoid things like immunotherapy and anti-HER2 therapy as well. So again, this can be a complicated situation, but the goal is to reduce the risk of breast cancer returning, and at the same time, concurrently with an equally important goal, reduce the risk of any adverse effect to the developing fetus. The other issue, of course, is in somebody who's had a prior diagnosis of breast cancer, what happens if they get or want to get pregnant at some later time point? And again, in this population, a younger group of women who either have never been pregnant or want to get pregnant again and add to their family, this is an important life goal. And one of the major concerns they always have is, by getting pregnant, am I throwing gas on a fire, and am I going to make my breast cancer come back? Am I going to make it accelerated, or am I going to have a worse prognosis? And to address that point, the answer is no. There's no clear evidence that by having gotten pregnant, you somehow make the disease worse or a higher risk of recurrence, and that's been shown many times. The other corollary of that is in a patient, for instance, who has hormone-sensitive breast cancer and are receiving anti-hormone therapy, often recommended for many years, a minimum of 5, and in some cases all the way up to 10 years. You don't want to tell a 32-year-old woman that she has to wait until the age of 42 before she can consider getting pregnant. So it raises the issue, can you take a break from anti-hormone therapy, try to get pregnant, succeed, and deliver, and then go back on therapy, and the outcomes being safe and equal to those that didn't take a break? And we've learned from a trial called the POSITIVE trial that By doing that strategy, in other words, starting anti-hormone therapy, usually we like to have patients on treatment for a couple of years, and then stopping and taking a break in order to try to get pregnant and hopefully succeed, and then after delivery, resuming the anti-hormone therapy. Has there been any adverse outcome that's been observed in these patients? And the answer is no. And this was a high-profile paper published a few years ago with subsequent follow-up showing that there is no adverse effect to taking a break from anti-hormone therapy. Women were successful in getting pregnant, and the majority of women did go back on anti-hormone therapy to complete the desired and expected duration of treatment to optimally reduce the risk of the disease returning. If you'd like to get more information about personalized treatment paths, including the different therapies that are available that might be appropriate for your situation, tailored to your tumor biology and health profile, you can get a Yerba report which breaks down chemotherapy regimens, endocrine treatments, and other combinations, and provides specific information that may be appropriate for your case. And you also have an opportunity to interact with Yerba's medical experts directly for evidence-based answers about your options, recurrence risk, or side effects from the therapy you have by going to yerba.com. One of the key discussions we have with young women before we start treatment for breast cancer is understanding what their goals are regarding potentially getting pregnant, having a family. And of course, in anybody who is open to that idea, we have to take into account what the effects of treatment might be on their chances of subsequent pregnancies. So we know, as an example, that when we first meet a patient, and if they're uncertain or they clearly want to get pregnant at some point in the future, we discuss fertility measures or ways that we can optimize their fertility or protect their fertility as they go through treatment. One of the ways that sometimes we do this, at least it seems to have some positive effect, is by shutting off the ovaries with an anti-hormone treatment, what we call a GnRH agonist, which basically sort of is a stimulus to the brain to fool the ovaries, and they become quiescent during chemotherapy. And this is often used as a way of protecting the ovaries. The other things we do is we often engage the oncofertility teams, and if you're at a big center, this is quite common. And what they do is lay out the options for patients, which may include protecting the ovaries, as I just mentioned, but it could also mean egg retrieval or embryo storage, if those are options to the patient. And we try to accomplish these things before starting systemic therapy, because once started, we don't want to interrupt treatment to do this. And it usually takes a few weeks in order to accomplish this. And for most patients, that's doable. But we always set expectations that chemotherapy, as an example, could push a patient towards menopause. Their fertility may be diminished. There is a correlation between the age of the patient and their ovarian reserves. So if they're getting treatment with typical chemotherapy drugs we use, the probability of getting pregnant can diminish as a woman gets older. So we always have to take that into account and make sure they understand and have appropriate expectations as we go into this. The final piece on this topic is the chances of being able to breastfeed following a diagnosis of breast cancer. So going to an extreme, if a woman has bilateral mastectomy, she has essentially no breast tissue, so there's not going to be any breastfeeding. If the affected breast underwent a lumpectomy and radiation therapy, milk production on that affected side may be diminished, and she still has the contralateral or opposite side where that could still be something that could be done. In other words, breastfeeding through the unaffected breast. The other thing we want to emphasize, of course, is that when women are getting treatment, we realize that some of the medications, the chemicals, can actually be transferred through breast milk. So we have to be very cautious in talking to patients about what they're receiving in terms of treatment and what the chances are that there could be any transmission of that medication to the baby. So these are all things that go into consideration and require discussion with your oncologist as well as with your obstetrician, gynecologist, when thinking about breastfeeding after a diagnosis of breast cancer. So the key points I've tried to convey to you is one is it is possible to get pregnant after a diagnosis of breast cancer. Not only does it not seem to have an effect on your overall outcome from breast cancer, but for those women taking anti-hormone therapy, it's also safe to take a break from anti-hormone therapy in order to try and get pregnant. For patients who have a diagnosis of pregnancy as well as breast cancer when they first present, we have to take into account, of course, the drugs the patient's going to be receiving. And our goals are not only to reduce the risk of breast cancer, but also to protect the developing fetus. And then with respect to breastfeeding, that's possible after a diagnosis of breast cancer. The milk production may be diminished in the affected side, but the contralateral side is intact. So there are options for women who have desire to get pregnant and have a diagnosis of breast cancer. We always try to engage the fertility people when we're starting down a path of treatment to try and ensure that all options are available to a patient to reach their goal of not only reducing the risk of breast cancer, but hopefully achieving a pregnancy in the future. I hope you enjoyed this Yerba YouTube video. If you'd like more information on your case, as well as the therapeutic options that are available, both the pros and the cons of different therapies, go to yerba.com. I've enjoyed talking with you, and I'll see you next time.